Hello friends and colleagues. So in this video I would like to share a video of a routine Phaco job in a nuclear sclerosis grade 2. So as you see, I've already made the sideboard incision with my MPR blade. I make limbal incisions just to take the faint vessels at the limbus. I feel that it gives a very good healing and very good post-operative result, good wound seal. We made a 2.8 incision with the Cataract knife, starting the rexus, aiming at approximately 5 to 5.5 round, well-centered rexus around the centered around the Purkinje reflex of the light, as we can see in the center. So that should be the aim, to center the rexus around the visual axis. It gives good IOL stability in the back with a good all-round 360-degree cover of anterior capsular margin over the optic of the IOL. So here we have completed the rexus and now proceeding towards hydrodissection. So we see the golden ring sign, uh, and we rotate the nucleus in the back just to ensure that it's free of any adhesions, post which we just reform the AC so that we can begin with emulsification. Patient is fairly cooperative. This case was done under topical anesthesia, and I like using a sharp chopper, just checking for the rotation of the nucleus, dipping the Phaco probe into the nuclear matter and causing the first job. So fairly simple, grade 2, grade 3 cases. Chopping is fairly simple. Just the forces needs to be correct. The Phaco probe needs to be at the center, dip sufficiently into the nuclear matter, and the hand with the chopper need to go like a fish hook and engage the nucleus and cause the separation to get a proper break, to get a proper chop. After the chopping is done, it's a practice that I follow. I remove the second instrument. So uh, this basically does not leads to PC coming forward due to another leak into the anterior chamber, and I find this technique fairly simple, a single-handed one, wherein I bring each and every chopped piece of the nucleus at the pupillary plane and emulsify them and aspirate it. So as you see, we've completed aspiration of all nuclear pieces. Now this is a very important step, that is aspiration of the epinucleus sheet. So it's very important. I have seen a lot of beginners struggle with the epinucleus sheet. So it's very important that we get rid of the epinucleus sheet with the Phaco probe itself, rather than trying to maneuver or trying to aspirate it with the irrigation aspiration port. So this thing I feel makes life fairly simple. After the epinucleus, the only thing that remains is the cortex, which is a very simple procedure to clean up. So once again, we form the AC and we introduce a coaxial IA. So for this case, I'm using a bent tip coaxial IA. Advantages with this is subincisional cortical removal cleanup becomes very simple. So we go beneath the anterior excess margin and slightly hold the cortical matter, bring it to the center, and then give maximum vacuum to aspirate it. So as I mentioned, the main advantage of such a bent tip is in subincisional cortical aspiration. So can just take it beneath the anterior excess margin subincisionally, just turn it around, and you know aspirating the cortex becomes fairly easy. Now finally, ensure that AC is well formed. The bag is filled with viscoelastics and introduction of IOL. For this case, we are injecting a hydrophobic acrylic IOL, and uh, so for beginners, make sure that the leading haptic goes inside the bag, and then gradually dial the trailing haptic into the bag. So, I've seen a lot of again beginners struggle if the leading haptic is not into the bag. Struggling to push the IOL into the bag. So, after putting the lens, I observed some cortical debris behind the IOL. So, just go behind the IOL in irrigation mode. Do not go in aspiration mode. Just tilt the lens and go with the probe beneath the lens and aspirate it, and then a regular viscoelastic aspiration to end the case. So one important step while hydrating your wounds is ensure that uh, you don't increase the IOP way too much. Suddenly, if the patient loses fixation, it is basically a sign that you need to deflate your AC and ensure a good IOP as low as possible. This ways you will see much clearer corneas the very next day. So I just check, I find it a little bit tight, and I release some fluid from AC. It's fairly simple, just depress the posterior lip of your main wound, and fluid would egress. So with that, completing this case, hope you liked it. Thank you.